Assalamu alaikum. This lecture is about angina and its therapy. Here start the first slide. Angina pectoris is the chest pain caused by transient myocardial ischemia due to an imbalance between myocardial oxygen supply and oxygen demand. Pain is sudden, severe, breaking chest pain radiating to the neck, jaw, back, and arms. Angina pectoris imbalance is the imbalance between oxygen supply and oxygen demand. Here, typical distribution of the anginal pain. This is a patient suffering from anginal symptoms. Usually, angina can spread anywhere between the belly button and the jaw, including the shoulder, arm, elbow, and usually on the left side. Types of angina. There are 3 types of angina. Remember all the time, this type of angina, which is called variant angina, vasospastic angina, transmetal angina, or angina inversa, contraindicated to be given a beta blocker. Beta blocker, as we are seeing in just few seconds, it is a typical or standard treatment, standard therapy in angina. But all types of angina, I could use beta blocker except this one. Treatment to increase coronary blood flow and decrease auto demand on the heart through vasodilators, including nitrates and calcium channel blockers. Decrease auto demand on the heart through administration of beta blocker or beta antagonist. Treating coronary artery disease and the risk factor associated through statin via decreasing cholesterol level, or in the final maneuver, when all medical treatment fail, we could do surgical intervention via a cardiologist through administration of stent or make angioplasty. Classification of the treatment: lifestyle modification, which is called general measures for stop smoking, reduce weight, treat hypertension, treat hypercholesterolemia and diabetes. It's called lifestyle modification and decrease the risk factor that are leading to angina. Then lifestyle modification plus, in the same time, of course, drug treatment. If this fail, we could do coronary artery revascularization. Anti-anginal drugs include nitrates, beta blocker, calcium channel blocker, and other anti-anginal drugs. The nitrates used in angina pectoris act on nitric oxide. Nitric oxide is present normally in the body, leading to vasodilatation. It is released from endothelium. This nitrate release nitric oxide and stimulate cyclic GMP. Nitrates useful in all the 3 types of angina. They are dilators for vein and artery. Okay? We have short-acting preparations and long-acting preparations. Nitroglycerin is given sublingual as a spray to terminate an acute attack. Onset very rapid, short half-life, just 3 minutes. Oral administration of nitroglycerin is ineffective. Why? It has first-pass metabolism and could be destroyed by the liver. High doses of nitroglycerin, which saturate the metabolic enzyme, can be given orally or topically as a patch for prophylaxis. Isosorbide dinitrate and isosorbide mononitrate, it is the metabolite of dinitrate, are long-acting nitrates that are useful for prophylaxis. Side effects of nitrate, because they are vasodilator for the artery and vein, so produce headache from vasodilatation, postural hypotension, syncope from vasodilatation of the artery. This hypotension making a compensatory reflex, leading to reflex tachycardia. Nitrate oxidizes the blood and produce metahemoglobinemia. Then prolonged administration of nitrate lead to decrease its effect, that is to say tolerance, and sudden stoppage of nitrate lead to withdrawal manifestations and rebound anginal attack. The second drug is beta blocker, produce its beneficial effects via decrease the heart rate, decrease contractility. But propranolol should be used with caution in metal angina or contraindicated from the start, and also it is contraindicated in asthma. The other contraindication, never giving beta blocker plus calcium channel blocker, except nifedipine. Why? To avoid heart block. Propranolol or beta blocker is the ideal prophylactic maneuver to avoid recurrent attack of myocardial infarction. It's important to avoid sudden stoppage of beta blocker to avoid rebound anginal and hypertension. The main last therapy for angina, beside nitrates and beta blocker, it is calcium channel blocker. They decrease the heart rate, myocardial contractility, and they are vasodilator for the arteries only, not as nitrate for arteries and vein, and also they dilate coronary vessel. Here, the combination therapy and drug-drug interaction. This is a summary, the important summary to know what is good combination, what is bad combination in a patient suffering from angina. This is a strategy or the therapy of treatment of angina, either stable angina in the acute attack or between the attack, and variant angina, and the unstable angina or myocardial predisposed, what we call, that's to say myocardial infarction. Unstable angina equal myocardial infarction. Here the treatment of an acute attack of angina, the summary, what we have previously explained and mentioned. Then the new anti-angina drugs, they have more significant name than new. They are not new now, but many books have this term. They are indeed an adjunct agents or adjuvants to the main line therapy of angina. Help nitrate, help beta blocker, help calcium channel blocker. They are, and not I think not all included in your book. Just to know what's included in your book. Ranelozine, trimetazidine, nucarandel, dipyridamole, aspirin. Just know the name, mechanism of action. Here the last slide about the therapy of acute myocardial infarction. This starts as unstable angina and developed as in the form of infarction. We have the three lines of treatment as angina: beta blocker, nitroglycerin, calcium channel blocker. But we add another therapy, another acute therapy as anticoagulant, fibrinolytics, sedative, relief of pain with morphine, and the first of everything is oxygen, because there is no oxygen enough. This is the pathophysiology of infarction and angina. And of course, all this therapy must be given in the coronary care unit. And thank you.